This is a preview of the lecture video on the topic left ventricular outflow tract in fetal echocardiography. The snippets of the various topics covered under this lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in. Left ventricular outflow tract. Again, I am stressing that I am going to, we'll see that little later. And then the essential sections taken are the 4-chamber view. They'll to go back for the other sections. And then also make a sweep, which is important. Besides the section, sweep is also important. Then 3VT and sweep. Now 3VT and sweep we have not covered yet. But for completion, to get a diagnosis, we have to go for the 3VT and sweep. So even though the 3, and then little more tilt towards the head, you get the LVOT, and little more tilt, you get the 3VT, 4-chamber view. And then when you tilt the transducer towards the head, you get the LVOT in grayscale and color, the apical and anterolateral. And most of the times, both sections will be necessary, as I explained already. So this is the axial sweep in the view. Instead of tilting the transducer towards the head, you rotate the transducer, atrioventricular connection, then the ventriculo-arterial connection, that is the LV-aorta connection. And you also see the ventricular septum, the ascending aorta, that formed by the septum and the anterior wall of the aorta. And when you see the aorta, there is a long curve. You'll see, and then in systole, it totally disappears. It has to disappear totally. You should not see the aortic valve in systole. If you see, then that is view. You see the LVOT, you see the aortic valve opening and closing. And then beyond that, if you see, you will see the RVOT, the branch pulmonary arteries, and the 3VT. Same in color, that is the flow across the AV valves. Then when you tilt the absent, and the direction of flow. So direction of flow again is important, blue across the AV valves. So that is the flow direction. When you make a sweep, then you see, I told you, then the pulmonary artery bifurcation. Now I want to explain more in detail about from the LVOT. When I go up, you see the pulmonary artery dividing into the two branch pulmonary arteries are in opposite color. Because in the right, it is towards the transducer, so it is red. In the left, say in this fetus, you see that both similar section, it is you see the spine, similar section, but you see both the pulmonary arteries in same color. You see here? So in the same fetus, so this is left lateral, and this is left lateral, and this is right lateral approach. I hope it is clear. Then we come to again angle of incidence application. Now here you see the LVOT, it is 90 degrees, so you don't get any flow, both LV inflow as well as outflow. So this is the tracing. This is placed at that junction. We get both the LV inflow and the outflow. That abnormal aortic valve or the LVOT may not be seen, and there may be an abnormal connection, left ventricle. And we go to the 3VT, you see reversal in the aortic arch. So the final diagnosis is hypoplastic left heart syndrome. So because the normal velocity is around 50 to 60 centimeters per second, so you must put it around 70 centimeters. If still a lacing is present, then it is abnormal. So narrow LVOT, dilated left ventricle, with a smaller LVOT. Then you look at the arch of the aorta. Here there is arch of the aorta is discontinuous. You don't see the arch of the aorta. When you do a sagittal scan, you see the ascending aorta continuing. When you do a longitudinal sagittal scan of the aortic arch, you see the narrowing diagnostic of coarctation of the aorta. When you do a color Doppler, again you will see a lacing. And when you do spectral, again the velocity is increased. So more than 100 centimeters per second. So that is aortic stream. Normal left ventricle, LAC, and increased PSV. The aortic stenosis may be critical, where the aorta will be narrow, the left short axis view. Now, short axis view from the four chamber view, for LVOT, you are rotating. So that is the LVOT through the ascending aorta. So from there, the Benz appearance, you see just an arch-like thing. Now that is the aorta, and you see the two leaflets closing. So that is the arc-like appearance of the aortic valve in a bicuspid, and the membranous part and perimembranous part, and you will see the coronary ostium. It is seen as an artery, the LVOT as seen here. So that is the bidirectional flow, and then you see the V that it is malaligned perimembranous VSD. So here you see the perimembranous VSD without malalignment, but here you see a VSD with overriding aorta. But see, overriding aorta, we cannot straight away call it aorta because it can be another vessel. So whereas pulmonary artery, it will be an acute curve. So the long curve towards right shoulder, this will be an acute curve posteriorly, and you'll see the early branch more than 50% to the ventricle. So that is connected to that ventricle. So based on this definition, the ventricular arterial connection can be, that is tetralogy of Fallot. If it is committed more than 50% to the right ventricle, then it is discordant and it is DORB. This pulmonary artery is narrow. So it occurs in 80% of the cases of VSD overriding. These are the features we see in VSD overriding aorta: pulmonary stenosis, left aortic arch, left ductal arch. We come to the narrow pulmonary artery, pulmonary stenosis, but the aortic arch is on the right side. So right aortic arch and right ductal arch. To narrow pulmonary artery, forward flow, pulmonary stenosis, right aortic arch, but left ductal arch, reversal of flow. So why does this happen? When there is pulmonary valvar atresia, you see in this diagram. So that is the pulmonary valve that is atretic, but the pulmonary artery is, the lumen is there. Here, pulmonary valvar atresia, but the aortic arch is on the right side, blue, again U, but the pulmonary artery is reverse. We come to dilated pulmonary artery. So this is dilated pulmonary artery, where the main pulmonary artery and branch pulmonary arteries are dilated, grossly dilated. So these arteries are normal. So that is the situation here. Now this occurs when there is pulmonary regurgitation in a pulmonary valve, the right ventricle. So the ventricular arterial connection is single. So here you see only a single vessel in 3VT. So in this situation, how to proceed further? You must look for the branch pulmonary artery. When you see in all these three situations, the opposite colors. But when you see like that, when the pulmonary arteries are arising from the proximal aorta, then it is common arterial tract. Then so it is away from the transducer. So both branch pulmonary arteries are in blue. When you see the same features from the right side, you see that the branch pulmonary arteries both are in red, because the left branch pulmonary artery is fed by from the duct, and it will be tortuous. So here you see the tortuous vessel from the distal aorta, not from the proximal. So distal aorta, you see arising from the descending thoracic aorta. So here you see the descending thoracic aorta, which is giving a vessel and which feeds the confluence of the branch pulmonary arteries. So one is now here what you see is the pulmonary artery is not seen. This is 13 weeks. So VSD overriding. In 3VT you see only the aorta, you don't see the pulmonary artery. But when you look for, you don't see any obvious tortuous vessels. But when you do a coronal scan, you see that the red, one in blue, arising from the inferior aspect of the same vessel, proximal vessel. Then we go distally, you see the single aorta. So when you see this is rare. You see the VSD overriding. Pulmonary artery is normal in the 3VT as well as in the RVOT. So when you see this may be pulmonary valvar atresia, when it is dilated pulmonary artery, absent pulmonary valve syndrome or pulmonary valve dysplasia. When it is not seen, it may be shown here. So in that case, the diagnosis is DORV of Fallot's type. So here you see the aorta arising more from the right ventricle. You can see that, and committed more to the right ventricle. So that is the overriding aorta, that is Fallot's type. And when there is pulmonary artery which is overriding, then that is called the TGA type. So DORV may be of TST overriding pulmonary artery. So when the overriding vessel is pulmonary artery and more than 50% to the right ventricle, then it is DORV of TGA type. It is clear, shown very well. Now, when the LVOT is not seen, so you are not able to identify the LVOT, it is an acute curve directed more to the posterior. So when you see like that, then it is abnormal. Then you must think of that it is a pulmonary artery. So that is the acutely angular curving pulmonary artery with branching. And when you come to 3VT, you see the single aorta, the I side. So that is the TGA. Thank you very much for your patient listening.